We're going to talk today about fertility tests and diagnosing infertility. Dr. Saravelos is one of our fertility doctors with Apricity, and he's going to be talking through all of the main tests that we use when we diagnose infertility for men and women. So the floor is yours.
Thank you. So let me share my screen. Hopefully you can see it nicely there. And I guess we were speaking with Holly earlier and we're saying how nice it is to try and make these webinars interactive. So we're literally going to spend only half of the session going through the slides and the other half having Q&As. And there's a lot of questions that have come through. And of course, some more can come through now as well. So we're quite excited and looking forward to it. So what happens when you're investigating infertility? Well, a little bit about the background. Infertility affects a very large proportion of the population. Millions of people in the UK and about 1 in 6 to 1 in 7 couples, which is a lot. There's a lot of reasons behind that. One is that as time has gone on by, in the last 50 years, the average age that we're having children has gone up. So we decide to have children later on in life, either because we are busy with work, or we haven't met the right partner, or we're not ready, or mortgages are too expensive. For a number of reasons, we're deciding to have children later on in life. There are other reasons other than just age, and the medical reasons. Number one seems to be often male infertility, the big neglected area of medicine for me. So male infertility, about 40% of cases. The women's infertility contributes to about 30%. About 20% is mixed. So it's a team effort when it's fertility involves men and women. And often there'll be a combination of factors. And 20% are unexplained. So we do all the investigations and we never find a cause. So a little bit about the basics of female infertility. So women are born with a set number of eggs. So actually, the eggs that a woman has at birth, which are about 1 to 2 million, are all the eggs she'll have for her entire lifetime. And it's almost as if they're suspended in time in a freezer. And over time and as we grow older, the number and the quality of the eggs slowly declines. Now, what we call ovarian reserve nowadays is a test that we have to count or estimate the number of eggs that a woman has left in her ovaries. And there's a number of ways we can do that. The two most popular ones are AMH, which is anti-Müllerian hormone. Now, that's a hormone measurement in the blood, and that comes from the eggs in the ovaries, and that gives us an idea of how many eggs a woman has left in reserve. The same or similar test with ultrasound scan is called the antral follicle count, where with an ultrasound scan, you measure the number of follicles, which are little sacs or little pockets that contain the eggs. And of course, the more of these follicles you have, the higher your egg reserve. Interestingly, even though it's 2022 and Mark Zuckerberg is making a metaverse and all of these things, we still don't really have a good test for the quality of the eggs. And probably the best test we have is simple. It's the age of the woman. So the younger the woman, the better the quality of eggs, because they haven't been around for that long. Now, I get asked this a lot, and I'm sure it will come through in questions as well. What does a low AMH mean? So the most important thing with AMH, the AMH test, is not to cause undue stress and worry. So a low AMH may mean less chances of a pregnancy with IVF. So it's an IVF test predominantly. A low AMH may mean less eggs with egg freezing treatment. A low AMH may mean that you need to be more proactive with your fertility. But AMH, again, measures the quantity, the number of eggs, but not the quality of eggs. So a low AMH does not mean that you cannot get pregnant. A low AMH does not mean that you're not ovulating. And in fact, there's a number of studies that have shown that the AMH does not predict your chances of a natural pregnancy. So the AMH is predominantly a treatment test more than a natural pregnancy test. Also, AMH is useful in cases where we're considering, or when women are considering egg freezing for social reasons, or when they're considering egg freezing for medical reasons. So I see women that have a diagnosis of cancer, like breast cancer, and their oncologist is about to give them chemotherapy, which can essentially kill the eggs. And what we can do is we can do fertility treatment to collect eggs, freeze eggs before they have chemotherapy. So the best scenario is that they have eggs frozen, then they have cancer treatment, they survive cancer, then they come back and we help them have a baby. So that's very rewarding. Single individuals and same-sex couples thinking about conceiving can also have an AMH test to see how they're likely to respond to treatment. How about the other end of the spectrum? What happens if you have a very high AMH level? Well, generally speaking, a high AMH level is great. It means you've got lots and lots of eggs. But if you have too many eggs, if there's such a thing, then you might fall into a category called polycystic ovarian syndrome, or PCOS, which is a condition where you have a hormone imbalance, almost because there's too many eggs around, and it can cause you to not ovulate. So therefore, some women, even though they have lots of eggs, they're not releasing them and they're not getting pregnant, and they have irregular periods. In terms of treatment, a high AMH may mean that you get a high number of eggs if you have fertility treatment, whether that's egg freezing or IVF. So again, that's good because your chances of success are higher. But as with everything, there's a catch. A very high AMH may mean you're at risk of developing what's called ovarian hyperstimulation syndrome. So that's when a woman's body almost goes into hormone hyperdrive. The hormones go through the roof. She has a bloated tummy. She can vomit, have pain, and feel unwell, develop clots, and it can be quite serious. Thankfully, in the last few years, we've developed medication that can protect against this OHSS. So we're hoping nowadays that we can get the best of both worlds in women with a lot of eggs, both lots of eggs, but low risk of complications. So the AMH test, as you can see, is a basic test that we do for women, couples that have infertility. Ultrasound is also super basic and absolutely paramount. It's performed by a sonographer or a fertility specialist like myself. Most of the fertility scans use a vaginal probe, and the reason for using a vaginal probe is because it gets very close into the ovaries and the womb, which is what we see in great detail. Sometimes from the tummy, you can't see them as clearly. Again, we can look at the ovaries and assess how many eggs there are with the AFC, antral follicle count, which is the ultrasound version of the AMH. And we can look at conditions such as endometriosis, fibroids, congenital abnormalities, anything that would stop us from getting pregnant. Typically, on a standard scan, you cannot see the fallopian tubes because they're so tiny and slim on the inside that unless they're very damaged, you won't see them. They're hiding behind the bowel. And that's where HyCoSy comes in, contrast sonography, or hysterosalpingo contrast sonography. So this is a scan, a vaginal scan, but it's almost like a smear test. We use a speculum and we put a little tube, and then we inject some dye to see if there's movement of dye through the tubes. That way we can see if the tubes are open or blocked. Also, it can open up the womb so we can see inside the cavity where the baby is likely to grow. It can be a bit uncomfortable, like a smear test, but it's very useful. Thyroid function test we also do. The thyroid function tests are essentially important because the thyroid, which is a gland in the neck here, can be associated with infertility, miscarriage, health problem for babies if it's abnormal. Thankfully, the thyroid problems can usually be very easily and effectively treated in women who are trying to conceive. And also, it's not just about having a baby, like we said, it's about reducing risk of miscarriage or keeping babies as healthy as possible. And we mentioned male infertility. again, up to 50% of infertile couples will have some form of male infertility. So we have to get men involved in the discussions. We have to stop talking only about women. It's a joint effort for most couples. And the male factor infertility frequently ranks as #1 cause for infertility. So this isn't a female problem. It's, a global problem. It affects both men and women. Interestingly, in the last 40 years, there's been a reported drop of sperm counts in up to half of up to 50%. And that may be to do with environmental toxins, the way we lead our lives, less activity, what we eat. But whatever we're doing, the sperm are not big fans, and that seems to affect our fertility. And of course, male factor infertility is damage to the sperm, and about 7% of men seem to be affected by it, which is huge, very high. 1 in 10, 1 in 20 men will have it. Thankfully, testing for men is easier. So in our initial screening of tests for men, all we need to do is a sperm test. And there's 3 main things we look at. We look at the sperm number. So often we can aim for more than 32 million sperm in a sample. And literally today, I've seen a gentleman who's had almost 500 million sperm. So there's a wide spectrum. You can have men that have billions of sperm almost, to men that have 0 sperm. And clearly, if there's no sperm at all in the sample, you can imagine that the chances of pregnancy will be negligible. The morphology is how the sperm looks under the microscope. So it's not just about the number, it's the quality of sperm. And the reason men have so many sperm is because only about 1 in 20 under normal circumstances appear normal. Other sperm have broken tails, they have 2 heads, and it is indeed called teratozospermia, which means a monster or a beast in Greek. So having abnormal sperm can contribute to infertility. And motility is movement, the movement of sperm. So even if you have lots of sperm and they look healthy, if they're not moving and they're wiggling their tail so they can go on a date with the eggs, then it will cause trouble in terms of getting pregnant. And again, this we tie along with the history, and lifestyle factors for men are very important. Previous medication, whether they had procedures as children or mumps, and all kinds of things we look into to see whether there's causes identified for abnormal sperm counts. And finally, in terms of testing, there are algorithms that we can use to test and assess the chance of natural pregnancy and also of fertility treatment. And Apristi has developed some of these, like the natural lifestyle fertility predictor and the fertility treatment predictor. In the natural pregnancy one, it would ask things like age and cycle and smoking and health habits, etc., which will all impact on pregnancy. For fertility treatment, this is based on 500,000 treatment cycles from the UK regulator, the HFEA. And again, we'll be able to give an estimate of what the chances of pregnancy are in both natural attempts and with fertility. So at 14 minutes, we're good on time, Holly. I'm going to stop sharing here and we can go to some questions.
Absolutely. Thank you so much for that. That was really clear. I feel much more informed myself. We had quite a lot of questions come in beforehand, actually, that people sent across when they registered. Some of them, I'll work my way through them. Some of them were around why am I not getting pregnant when I've done all of the tests? Another person asked, I've been trying for 1 to 1.5 years and I'm still not pregnant. What can I do?
Shall we tackle them one by one?
Yeah, absolutely. So why am I not getting pregnant when I've done all of the tests and nothing's come back?
So that falls under the group of unexplained infertility. So unexplained infertility is basically when you've done all the tests and you can't find any answer. It is interesting because usually as medical professionals, when everything's fine and a woman or a couple are healthy, we're actually celebrating. And we're quite happy because it's good news. But when you see women or couples, they're actually generally quite upset and a bit stressed. And they're saying, well, what's wrong with me? Even the tests don't show anything. So about 20% will have, 20 or 30% will have unexplained infertility. Now, it could be that it's just something subtle that the tests aren't picking up. It could be that in 20 years from now, we would have some fancy molecular test where it shows that the sperm and the tubes are such that the sperm can't swim up the tubes, or there's something on the shell of the egg or on the membrane of the sperm that doesn't allow them to fertilize. We're just not good enough in 2022 to find the answer. Having said that, the good news is with unexplained infertility, there's often lots of treatment, which is great. And that's what I tell couples. I say, well, in a way, it's a blessing, because I see couples where the partner may have no sperm, and there's no real treatment for that other than, sperm donation in some occasions. Or a woman may have no eggs, so then she would need egg donation, which is fine, but often it's preferable to have all the tests be normal. So the take-home message is, it can be frustrating, but these couples usually do well with treatment, and there is an answer to it.
Okay. So another question that someone came up with is, I've been trying for 1 to 1.5 years. What advice do you have for me? We've been trying for such a long time. What do you recommend?
I think in terms of when to investigate, it's all a matter of balance. Sometimes I spend a lot of time reassuring couples that they don't need even testing done if they've literally tried 3 or 4 months, because there's nothing worse than taking people through tests and treatments and invasive procedures when actually the following month they would have naturally got pregnant. Equally, if I see couples that have been trying for 5 years and now they're at an age where the chance of success is low, you kind of think, oh, I wish they sought help earlier. So the national guidance generally, and the advice tends to be that if you're under the age of 35, where you still are likely to have lots of eggs being available and be very healthy, you should consider help after a year of trying. But if you are over the age of 35, you should seek help a little bit earlier, so after 6 months or so, because there is quite a quick decline in particularly female fertility after the age of 35. So if someone has been trying over a year, it's probably worth having a review or doing some tests. But again, I wouldn't jump in and start panicking after 3 months. Only if you're over 35 and you've been trying for 6 months or so, it's worth investigating.
Okay. Another question that we had was, in fact, there's 2 around fibroids. So we had one from a 42-year-old woman who had fibroid surgery a year ago. Will she still be able to conceive? And someone else asked, how can I be pregnant with fibroids?
Yeah, so fibroids are very common, so it's not a surprise that people ask about them. About 1 in 3 women I will see in clinic will have fibroids, and some women are more likely to have fibroids than others. With fibroids, it's all about individualization. So there are some women that have small fibroids outside of the womb, and that literally will cause no problem at all. And before we invented ultrasound, lots of healthy women having loads of babies had fibroids and we never knew about them. There's 2 things to watch out for fibroids. One is the size. If you have a small fibroid and it's not in a worrying position, and I'll come back to that, then it's unlikely to cause trouble. If you have a very big fibroid, then that's likely to cause trouble and you need to have that operated on. Now, in terms of the operation, there are some operations that are really straightforward, and you remove the fibroid without having to cut the womb too much. And actually, the surgeon will say that you can have a natural pregnancy and a natural delivery, and the fibroid is as if it never existed. Other cases, you have to actually cut the womb open, or maybe cut in many locations if there's lots of fibroids. And then the surgeon would say, you have to monitor this very carefully in pregnancy. And when you're about to deliver, it's not safe for you to have a natural delivery because the contractions could cause what's called a rupture, which is the womb basically tearing and tearing apart, which sounds scary, but it's something you'd be informed of in an operation. And in that case, you would do a cesarean section without allowing the womb to contract through labor, which could be dangerous. So that's about number of fibroids, size of fibroids, and operating on fibroids. The other thing about fibroids is the location. If a fibroid is inside the womb where the baby grows and where the period comes from, studies have shown that those are the ones that have the biggest impact on fertility. So those often have to be treated. And usually once they're removed, it's as if they never existed, which is amazing. The further away fibroids are from where the baby grows, the less likely they are to have an impact. So for this lady, I think you mentioned she's 42, I think, or for this lady with fibroids who had treatment, the best advice would be for the person who's the surgeon who operated to go through with her on what that means for pregnancy. If the surgeon is not necessarily of a fertility inclined, let's say, then with as much information as possible through that surgeon, a discussion with a fertility specialist will guide her as to what the impact is on fertility, because it's not a black or white thing. There's a massive spectrum and it has to be individualized. Of course, that's a long answer. I'm sorry about that.
I put myself on mute, so I didn't have any background noise. No, that was really good. Thank you. We also had a couple of questions about endometriosis. One person asked, can I conceive if I have endometriosis? And another person's asked, how does it impact fertility?
So endometriosis is thankfully in the media a lot recently. And that's because studies, it's been a while now, but studies have shown it can take 6 or 7 years to diagnose a woman with endometriosis. And there's a lot of women suffering from endometriosis. Endometriosis is where cells from the lining of the womb grow outside of the womb. And because with menstruation, with periods, these cells may bleed, they often cause scarring as well. So you end up, endometriosis can cause all kinds of problems. You can end up with scarring in the tubes, so the tubes can be blocked, or if these cells go in the ovaries can fill with cysts that are called chocolate cysts because they've got old blood that looks like chocolate. In rare cases, these cells can go up to the diaphragm. They can be found all over the body. Now, interestingly, there are some women where endometriosis causes debilitating pain, and they literally take time off work. They can't have sex because of the pain it causes. It's really an awful disease. There's other women that may have endometriosis and they don't even know about it. And they're lucky in that respect. So it can present differently in terms of how women feel. Equally, with fertility, there's endometriosis, which is very subtle and women can still get pregnant. If endometriosis is quite severe and it causes scarring and blocked tubes and cysts, then often there will be fertility struggles. And in those cases, fertility treatments in combination with an endometriosis specialist is the best approach. And again, together, dealing with the endometriosis and also targeted fertility treatments frequently really do lead to good outcomes. So once again, it's such a wide spectrum of disease that you have to look at it individually for each patient and make a targeted plan. But final kind of take-home message, endometriosis, same as fibroids, does not equal necessarily, infertility, or doesn't mean you can't have a baby. So it just means that you need to have it investigated and, understand your own condition in a bit of depth.
Okay, thank you. I've had quite a few questions also coming in on the Q&A, so I'll try and come through some of these as well. One of them here is, how can I be pregnant with polycystic ovaries, having previously had 3 rounds of IVF, but very sadly lost my daughter. Second was unsuccessful, and the last was successful. I want to have a natural pregnancy, but I don't have any periods. What can I do?
Yep, polycystic ovaries is another really important and big topic. Again, it's difficult to comment on a specific case without having all the medical notes and all the results. But polycystic ovaries, often what that means is that you have lots of eggs, which is a blessing, but your hormones are imbalanced and you may not ovulate. Having said that, some women may ovulate every 3 or 4 months, so they may get pregnant naturally, even if their periods are very irregular. The way to approach polycystic ovaries is firstly to make sure you've got the right diagnosis, because lots of women are told they have polycystic ovary or polycystic ovarian syndrome, and they don't actually have the syndrome, and that causes a lot of extra stress. The second thing is see how you can help them ovulate. So that can be with tablets, it can be with lifestyle measures, it can be with some injections. IVF can be used if none of the previous ones work. And again, we touched upon lifestyle measures. They can be quite important for health, not only in terms of conceiving, but in terms of miscarriage risks, because there is an association or a reported association with polycystic ovaries and miscarriage. And there is an association with polycystic ovaries and diabetes in pregnancy and beyond. So I guess the take-home message with polycystic ovaries is it's not just one single problem. It can affect, it's a condition that kind of travels through time and can affect you before conceiving, during conception, during pregnancy, and later on in life. So measures, I guess it's best if you're followed under by a team who can look after you, throughout the whole of your journey with fertility, pregnancy, etc. Again, I would tell this lady I'd be hopeful, because women with polycystic ovaries and the syndrome have lots of eggs and often do much better than women who have a low number of eggs, something that's called premature ovarian insufficiency. So there can be struggles with polycystic ovaries and polycystic ovarian syndrome, but we see a lot of women with the right care and support doing very well indeed.
Okay, thank you. I'm not sure if we're going to get through all of them. There's quite a few, but there is somebody who's put a question at the start around hormonal imbalances and high prolactin. She's been recommended to have a HyCoSy as well, but has really bad pelvic pain, and she's in her 40s. What would you advise to her? She's considering going on letrozole.
Yeah, but it's difficult to give advice on a webinar.
I think we've got a few of those. I think, individual medical advice is tricky.
Individual medical advice is tricky, and it's against our kind of good medical practice codes. But we can offer kind of support in terms of, well, if we approach one by one, having hormonal imbalances is something common. And there are ways that we can counteract that. So, a woman is mentioning low progesterone, and progesterone is a medication that we can give at the right time of the cycle. For example, it can help. Low sperm counts, often we need to see how low they are and whether the sperm count is enough for someone to have a pregnancy naturally or with insemination, or if they need IVF treatment. And I guess the take-home message here is putting all the puzzle together. So a lady's hormonal imbalances with the sperm counts, and seeing how you combine those and what the correct treatment is. Because imagine if a woman has hormonal imbalances and low progesterone, and you give her medication and you help her ovulate, and you give her progesterone and you support her progesterone. If her husband has a low sperm count, actually it may be that all of the efforts that you've made may not help if the sperm count is too low and the treatment is wrong. So I think the take-home message here is that, similar with HyCoSy, checking the tubes. HyCoSy is great to check if the tubes are open, again in combination with the sperm count. If the sperm count is too low, even if the tubes are open, it may be that naturally or with insemination, pregnancy doesn't happen. So there's some cases where if the sperm counts are really, really low, we don't advise HyCoSy because the tubes, whether they're open or not, would not change our management plan. So again, here I would say it's important to look at the details, look at all the information together, and with your health professional, fertility specialist, ideally sit down and go through all of them and make a plan, a joint plan together. I think that's as most as we can really contribute without it being a full consultation, which we cannot do on a webinar.
I'm conscious of the time as well. It's 1 o'clock. I don't think we're going to get to all of the questions. I'm conscious that you may have a clinic. So I think we probably have to leave it there, and say thank you so much for all of your insightful knowledge and considered answers. It's been really, really helpful. And we have recorded this webinar, so we will be able to share that with everybody afterwards.
Great.
And I will go through and see if I can pull through some of these questions, and we might be able to answer them elsewhere at some point.
I was going to say we can look at them offline or in the next webinars. So
exactly.
We're not really going anywhere.
No, certainly not. So thank you very much.
It's a pleasure.
Thank you very much, Soti.
So thank you to you and everyone joining, and have a lovely afternoon.
Thank you. Bye-bye.
Bye.